Good evening, everyone, and thank you for joining tonight's clinical webcast, Navigating the Dry Eye Labyrinth, How to be Successful in the Management of Ocular Surface Disease. This webinar is brought to you by OCULUS. First off, I'd like to point out on your GoToWebinar control panel, there is a section for questions, and I encourage you to type in questions during or immediately after the presentation, and we will conclude tonight's webcast with a Q&A session. Our speakers today are Dr. Crystal Brimer and Dr. Paul Karpecki. These are truly two of the leading experts in optometry when it comes to ocular surface disease management, and we're so thankful that they were able to be here tonight to do this webcast. Most of you will recognize Dr. Karpecki as the Chief Clinical Editor for Review of Optometry. Dr. Karpecki has written and lectured extensively on the subject of dry eye disease. Dr. Karpecki has served as co-chair of the Optometric Dry Eye Summit, committee member for the DUES 2 Diagnostic Subcommittee, and co-chair of the Tear Film and Ocular Surface Society. Our other speaker, Dr. Brimer, has been serving her community in Wilmington, North Carolina since 2000, where she focuses on dry eye disease. She has written many articles and lectured extensively throughout the country and the world on ocular surface disease. And currently, Dr. Brimer runs the Dry Eye Institute, which is a program that allows optometrists to learn the secrets to success by attending a small group of for a very focused all-day workshop. Dr. Brimer has also worked very closely with the Oculus development team to create the Crystal Tear Report for the Caretograph 5M, which has really proven to be a valuable tool for the practitioner by improving workflow, efficiency, patient education, and patient compliance. So on behalf of Oculus, I'd like to thank both our presenters here, as well as all of you in attendance tonight. And without further delay, I'll turn it over to our first speaker, Dr. Crystal Brimer.
Thank you, Chris. There we go. All right, so you should be able to see my screen now, and just again, thank you for joining us. You know, when we think about dry eye and why it's such a maze, it's not really that big of a surprise because patients are delayed in getting treatment. They self-medicate, they self-diagnose, they tend to move from one doctor to the next, and even if the doctor has a really great plan, there's not always that motivation for compliance, perhaps because of a lack of understanding. And then on the doctor side, we've got multiple simultaneous things going on that make it very complex. We've got patients with similar symptoms but different underlying causes, and it ends up leading sometimes to this trial and error approach, which brings frustration to both the doctor and the patient, and it adds to chair time, and it just, we want good outcomes. We want consistent outcomes, and we want to take care of the patient. And what I've learned is that if I stick to my little three-step solution here, it has really changed that for me. It's helped me to get those better outcomes and to relieve some of the patient frustration in this process. One of the most important things, I think, is creating a screening that is effective in your own office, that works with your flow, works with your staff, that you can do every single year, every single time, so that you're actually identifying it sooner. And that is just key. If we can identify it sooner, then we can change outcomes. I've seen just firsthand what a difference it makes in implementing treatment at year 1 versus 2 and year 2 versus 6, and how much less of a struggle it is to get where we want to go. And then in doing that, really taking a step back and looking at the presentation of the patient and spending the time to differentiate that diagnosis and then pair it with treatments that work. All of that is good and well, but if the patient doesn't really understand it, they're still not going to do it. So spending that time that's needed also on the patient education piece. So for me, this is what has worked, and it's worked so well, I think, because I use the 5M to do that. It's the cornerstone of my practice when it comes to dry eye, and I use it on every single dry eye patient that walks through the door, and actually every single patient, period, that walks through the door. I use its camera capabilities. It's a high-resolution camera that does photography and videography in 3 magnifications, but the other capabilities that it has because of its hardware really add a lot to the data that I'm collecting. I'm able to do interferometry and see the oil in the tear film. I'm able to do mybography. I'm able to do fluorescein videography and photos, and I'm able to see that tear film dynamic and the debris that's in there, the movement. I use it for my dry eye screening, and personally, I use the one that's built into the system, which is tear meniscus height, non-invasive tear breakup time, and the redness score. I like these because in my mind, it's given me a snapshot assessment of water, oil, and inflammation. I also like it because my technician can acquire it, do the assessment with the provided scales, and print out the report within 2 minutes. Now, if I want to make it quicker, then I'll trade out the non-invasive tear breakup for interferometry, and then we're looking at about 1 minute and 15 seconds. So it is not something that slows you down, but it's something that gives a ton of information to both the doctor and the patient. And they walk out the door with this screening report that gives them a status of their water, oil, inflammation, definitions of the test, and then kind of a warning / pep talk that plants a seed. It tells them symptoms that they may or may not be having or what to look for. And this either encourages them to come back for that full dry eye evaluation, or it plants a seed for next year so that you've had that conversation. And if symptoms do come up or they're thinking about dropping out of their contacts, they're going to remember this. They're going to come back to you instead of thinking, well, they should have caught it, and going down the street. But the bottom line is find a screening that works for you. For me, that's it. But if you want to do speed questionnaires or whatever it is, the point is identify them. And that's a really big first step in taking better care of these patients and creating better outcomes for them. If you don't, you're going to miss opportunities if you just wait for them to complain. And number two, I bring them back. Don't ever try to combine this with that original exam. I bring them back for the full dry eye evaluation. And my goal in this is to break down what's the underlying diagnosis. If I know if there's enough water, oil, allergy, inflammation, bacteria, lid function, systemic, environmental, if I know that, then I know what to do about it. And all I have to do is show them and create that compliance to get where we need to go. I can't do it alone, though. It really does help when you have staff support. And what I've found is that the way to really empower the staff and to get them on board is helping them know what to do. And with the 5M, I can create this work list where they know exactly what to do when it's a full dry eye eval, a mini dry eye eval, a follow-up with symptoms, a follow-up without symptoms. And not only do they know what to acquire, they've got an example image of exactly what it should look like and instructions on what to tell the patient or what to do, what to focus on. So it really empowers them, and it makes them part of this, part of the outcome, part of the process. And that's important in fulfilling your staff and having them bought into dry eye in your office. And the 5M does a really good job of that. And then how do I use that information to get to the diagnosis? Well, if you look at those categories I listed, there are multiple tests that can be done with just the 5M. Now, and when I say just the 5M, I mean I'm leaving out a red thread test and things like that. I'm just showing you the ones that you can acquire with the device. But all of these categories are very well covered. And you don't have to do all of them, though. But you need to find something, in my opinion, in each category so that you know, all right, is it a yes or is it a no? What direction do I need to go? And for my full dry eye eval, it covers all that, and I can tell this story to the patient, and we'll kind of look at that and walk through it in just a minute. But let's say you don't have the time to do that. This takes about 12 minutes to do. Let's say you only have 5 minutes. In 5 minutes, you can acquire these 8 acquisition items that will actually hit all of those diagnostic categories. And it can give you that story to tell the patient so that you can create that compliance. So in that 5-minute eval, again, all the things in blue are touched on, and it covers each category so you can have that yes or no. And if you just kind of pretend with me for a moment that this is the same patient as we walk through these pictures and kind of listen to how I would explain it. Basically, if I'm acquiring these items in blue and I'm telling them their story, I'm going to say, okay, you see here there's not enough water. We've got a fourth of what we should have. And then you see here, I'm not getting good oil out of these glands. These glands are backed up, and what you're creating is not good clean oil. It's thick toothpaste. It's Crisco instead of olive oil. And I know you're not getting oil in your tear film because there's no color in here the way that there should be. It should be like a prism, a rainbow. I want to see a rainbow in here, and I've got nothing. And what happens is this is causing your tears to evaporate more quickly than they should, which is making you have to blink more frequently. And you can see on this video, you're not blinking all the way. Those lids aren't closing, which is now causing structural issues. In addition to those structural issues, when that oil doesn't come out, it's a one-way street. It can't come back in. And so now we're having gland loss because the body's response is not to keep making more oil that it can't go anywhere. It's to shut that gland down over time. And this is not repairable damage once these glands are lost. And you see here on the bottom left, this is what normal looks like, and here you are. Now, as a side note, this has been so valuable to me, this sliding scale, because I used to talk this to death, and I was, talking to them about procedures and treatments, but I was using this laminated sheet of paper showing them what normal was supposed to look like, and they just didn't connect it, even when I showed them their own pictures. And with this, it saves me so many words and so much effort, and it clicks with them. They see it immediately. Their first question is always, can I get them back? And then we move on, and I say, okay, and look at what is happening to this tear film. Look at this migrating makeup that's getting in there, and look at the bacteria and the debris in these lashes. This is causing this toxic environment of the tears, and that's what your eyeball's bathed in, and it's creating this additional inflammation to what you already have, and this structural damage and redness. And so basically with just that 5-minute eval, I've got 8 of the 9 pictures in my collage, and I'm able to tell them this compelling story to help them understand what their status is and make them compliant again to do and what I ask them to do. And the reality is, it's not that hard once you have the diagnosis to know what treatment to put with it. We've got some amazing treatments available to us. The bigger challenge is when to use what so that it's not a trial and error approach. Now, if I do the 5-minute eval, what's missing from it, what I leave out? I left out topography. Now, if I see a nodule or something that warrants it, I'm going to go back and add that in. I also left out the non-invasive keratograph breakup time. What I do love about this test is that obviously it tells you each little quadrant and how many seconds it takes for those tears to break up in that quadrant. You see the first breakup time, and you see when the patient eventually blinks. What I really like about it, though, is it's the one opportunity for me to visually connect the dots for the patient and connect the potential vision consequences to the comfort and the ocular surface, because patients may be thinking, well, I can tolerate this. I can tolerate the dryness. It's not that big of a deal, because in their mind they don't see it as being progressive. But when they realize that it's also has the ability to affect their vision, and when they see these mires getting distorted, and I tell them, those rings are not on your eye, they're in the bowl. I say, oh yeah, well, they're reflected onto the tear film, and as your tears start to break up, that's what's causing this distortion on the rings. The same thing's happening when you're looking out. And that's why you're having to blink more frequently. That's why your vision is blurred. And for a lot of patients, that's an even bigger motivation to do something about it and to be aggressive. With the 5-minute eval, I'm skipping over the lysine green, and I do like what it tells me. I like seeing those staining patterns, seeing if there's SLK, seeing if there's exposure. I like evaluating the line of marks and being able to educate them on that. I like seeing the lid wiper epitheliopathy and being able to track that progress over time. So depending on what level of eval you're doing and how in-depth you want to go, you can add these things to that mini dry eye eval. I love taking this picture because just today I had a patient who came in a little bit worse, not really knowing she had any allergy symptoms at all, but yet I went back to that first day I saw her and I had taken this picture, and she had gone from a grade 1 papillae to a grade 3 with a little bit of allergic mucus, but yet not really aware of any allergy symptoms. But it led me down the road of which treatment I'm gonna go for. And then finally, it's, again, well and good that you know all this and you know what to do, but if they don't get to hear it and see it, it's not good enough, because the weak spot is the patient. You're not going home with them. And so you need them to be just as motivated as you are at making progress and going to that next level and improving their outcomes. So when I have my patient education story, I just told it to you in bits and pieces, but to put it all together in a 30-second outlay for the patient, I say, you see here, you're low on water, and look at these glands. See how they're puckered up? That oil is not coming out. And I know that because there's no color in the tear film the way that there should be. Uh-oh. Go back. There's no color in there, and it's causing those tears to break up too quickly. It's just causing you to have to blink more frequently, and it's causing this long-term structural damage that we can't undo to these glands. There's a lot of debris in the tears. It's causing this redness. It's causing this inflammation and that structural damage. And they get to see their eye, and it means something to them. At this point, my technician actually assesses the results based on what I've laid out for the patient. And then I have treatments that are already saved into my 5M. And so we'll do the assessment and we'll click on my mild, my moderate, my severe treatments, and then we print out a report for them. What's so valuable to me about this report is that I have something I can send home with the patient, but also to the referring doctor. It categorizes their issues according to severity. It shows which tests I did in each category, which treatments are specific to each category. And then it has a definition of all the tests that were done. And finally, a summary of all the treatments that I'm asking them to do. So whether they read it or not, it just shows them that we've got this. We've got this under control. We're doing something that no one's ever done for you before. And we're going to look at it differently. We're going to give you a different solution that's actually going to change things. So as far as patient impact and buy-in, it has changed it exponentially for me in my practice. It's helped their understanding. It's saved me time, saved me words, and just really that visualization, not just for my patients, but again for my staff, the buy-in from them to what we're doing and what our mission is, and the experience on all sides. It has definitely generated referrals and revenue. One thing I hear almost every day is, so-and-so sent me to you because they said you have the equipment. And it's almost like permission for these other doctors to send to you, because they're not saying you're a better doctor. They're just saying, you know what, I don't have the equipment for that, and she does. And so it makes it just such an open relationship that is very permissible on all sides and welcomed. What I've found in my experience, my personal experience, is when I focused on the outcomes, because when I opened the practice, that's all I cared about. I didn't realize what was about to happen. A year later, I looked and I said, wow, we did well. How did that happen? It was because of the outcomes. The outcomes generated the referrals. It generated the growth and the revenue. So I said, well, how in the world did we get those outcomes? And it wasn't because I was doing something magical. It was because of the patient compliance. And the compliance came because of the education. And then really taking the time to break down that diagnosis and pair it with that education. And for me, that was the key. At this workshop we do every month, it really, if you want to know more about the 5M and using it in this manner, we definitely go into a lot of depth, and you see it firsthand with that patient and how it can be used for that purpose. So that's all I have. I just wanted to give you some basics and let you see the capabilities, the hardware and software capabilities of the device, so that you could visualize that in your practice and how it might fit in. I'm going to turn this over now to Dr. Karpecki, and he's going to wrap it up and just bring in a lot of clinical experience and his expertise on that side to pull it together for you. Thank you again for listening, and we'll still be here for questions at the end.
Great job, Dr. Brimer. That was really a good clinical applicable presentation and really well spoken. So I'm honored to get to share the webinar here with Dr. Brimer. Obviously, she's done a lot of work with OCULUS, including the reports that she has so well refined. But I'm going to take you through a little bit of the clinical applications, but I'm going to use the reference of the DEWS 2. I wonder how many people on the phone have read all 400 and some pages of the report, so I figure I've got some new stuff here I could present to you, because I haven't read it either, but I'm going to give you the summaries, which are produced in 50 correspondence, or in like 50-page correspondence, or even in the 10-page. And I practice in Lexington, Kentucky. I also see patients in Louisville. I'm on faculty as an associate professor in U-Pike College of Optometry. Those are my main dry eye areas. But I'm going to tell you some neat stats to start this out. there's over 344 million people in the world with dry eye disease, making it the most common disease that we may well face without question. But if you just take what's going on in the U.S., it's between 30 and 50 million people. Some people, there's a study estimated 42% of all patients that see an optometrist or ophthalmologist have a primary or secondary complaint related to a dry eye disease. So that would really put it somewhere in the neighborhood of about 45 to 48 million people, if that was the case. The current number of patients diagnosed based on CPT codes include tear film insufficiency, KCS Sjogren's, only 16 million. So we're missing anywhere between 50% and 75%. But here's the most amazing statistic: the current number of people being treated. Yeah, this means an on-label drug, so this would have to be Xiidra or Restasis currently. Those are only two on-label for dry eye drugs. It doesn't include corticosteroids, which do have a great role in dry eye, but just those two, it's 1.4 million. So out of 50 million, we have an incredible opportunity here, and I think it's these technologies like the OCULUS that are going to get us there and going to make a difference for our patients. Now, this is a statistic I mentioned earlier, where 42% of all comprehensive eye exams had a complaint related to ocular surface disease. This was the optometric data. Ophthalmology data was not far behind at 38%. But what's interesting is that optometry currently performs 88% of all comprehensive eye exams. That means that roughly 40% of all the exams seen by our profession probably have a dry eye component, depending on the level it's at. It's the number one reason for contact lens dropout, which has a huge impact on optometric practices. And when patients drop out, they usually don't send you a memo saying, I'm leaving. They just kind of leave. And so it is something we don't even realize the impact of what it has. An average contact lens patient generates about $300 per year to a practice. That means they probably buy some optical and other things. So if really you lost, between 18%, some say it's 24% of patients a year, seems like a high number, but that's what a UK study just recently showed. But let's assume it's only 16%. That's still about, $3.3 billion. So it's not because we're doing it for the money. It's because it's the patient's best interest. And the number one reason they drop out is going to be ocular surface disease. So being at the front line, seeing 88% of all comprehensive eye exams, really it becomes our responsibility to diagnose and manage these patients. So the DEWS 2 revised definition really comes into importance here because it does talk about multifactorial. I mean, there's many things that contribute. We certainly know digital devices are the big reason we're seeing so much of this when the blink rate goes down 75%. It's characterized by loss of homeostasis of the tear film, where that plays a role. There's symptoms and tear film instability. It has hyperosmolarity, ocular surface inflammation and damage, and even neurosensory abnormalities all play etiological role. So this really has got us to a point of understanding that there's a lot we have to look at, but we want to simplify it today. And simplify it meaning is that one way to simplify it is just to simply say that if you look at, I think my computer's frozen here for a moment, but if you look at the dry eye as a lacrimal functional unit, the entire ocular surface and the system, and this was first coined by Berabino coined it, but Flugfelter referred to this very early. And that is the fact that the tear film, the lacrimal glands, the conjunctival and corneal epithelium, and the meibomian glands are all connected into one unit, all controlled by nerve connections and systemic hormones. So a lot of dry eye is not even in our control. It's hormone regulated. But there are contributors that can increase the risk factors like digital device use, contact lens wear, especially if they overwear, or use lenses extensively, refractive surgery, female hormonal perimenopausal medications, antihistamines, the list goes on. And everything here contributes to dry eye. Now, in my clinic, I get these patients. I have over 420 Sjogren's syndrome patients positively diagnosed. So the only reason I know that is we're doing a study on them, and we need to know how many we have. And so this is what I see, patients who are down to their last few nubs. And they all look at me and they say, Dr. Karpecki, could someone have done something for me before I got to this stage? And I like to go back to this slide here and kind of answer it for patients, because the truth is the answer is no. We didn't know what to do 10 years ago or 15 years ago. And this is considered one of the top groups in the world that came up with dry eye. And I'm not putting this group down because I was one of the members. This was the Delphi International Task Force on Dry Eye. It was considered the top 25 clinical experts in dry eye in the world. What they mean by that is that there were some researchers, don't get me wrong, but these were people who saw a lot of patients. And so it was a unique group that got together. 2003 was our most recent meeting. I'm also part of DEWS 2 and TFOS DEWS 2, and all those committees. So it's carried on in those. But this was the original group, and you'll look in the bottom right-hand side, you'll see that there was a publication, lead author Ashley Behrens, in Cornea 2006. And this group decided and came up with the fact they did some great things. Number one, when you first look at any dry eye, the first thing you want to differentiate, is it lid margin disease involved or is it not? And actually at that time it was fairly revolutionary. In 2003, a lot of people were not thinking of expressing meibomian glands. Maybe Don Korb was, because he was so far ahead of all of us, but there weren't a lot of people that knew exactly what to do back then. And so this was kind of revolutionary to involve the lid margin that early. And they tried to change the name to dysfunctional tear syndrome instead of dry eye. Obviously that never caught on, but it was a pretty neat idea. But I'll take you to the very first bullet. This came out of the abstract in the Cornea Journal, lead author Behrens, and it said the most common presentation for dry eye disease is no lid margin disease. You know what that means? That means these top 25 experts in the world in 2006, because that when this was published, so 12 years ago, were completely wrong, 180 degrees off. They're actually the most common form of dry eye. In fact, 86% of all dry eye involves the lid margin. And so my point is, we didn't know what to do 10 years to manage these patients, and many of them most progress. And that's the problem with this disease. It's very progressive and it's chronic. Once you get past a certain point, it can really take off. But I will tell you, after this webinar and the more dry eye stuff you do, the more I think now we do have an obligation to know what to do going forward. But we didn't in the past. And all of this contributes to the tear film. So one of the great ways to look at it is these expert consensuses. I really love what TFOS Dues 2 did in their most recent publication. So I was on the diagnostic committee, so I'm going to go through the diagnostic section because the one I know the best. But what I liked about what they did is they had incredible individuals involved. James Wolfson, I mean, I could just go through the list, and they're all people that I admired. He was the lead of our group. And to his credit and the entire group's credit, they added clinicians to the group like myself who, I mean, I do some research, but I don't think I'd be considered of the quality of researcher. I mean, to their level, they publish. These are the great Kelly Nichols and people that really do a lot of stuff in this area from a publication research standpoint. And I see a lot of patients. I see 40 to 50 a day. It's packed in. I have a good staff. A lot of cornea, a lot of ocular services. So to their credit, they took a lot of us that did that. In my committee, I was probably the only extreme clinician. So they relied a lot on their research, but then said, okay, Paul, does this really happen? How does this fit in? So I think we came up with a great clinically applicable algorithm because of that combination of these brilliant people who knew everything in the research and people like me who saw a lot of patients. And as you put that all together, we came up with this thing about starting with triaging questions. And then I'm going to show you how the OCULUS fits into this. And then you went to risk factors. Is a person contact lens wearer? Do they smoke? Are they on antihistamines? Once you have an idea that it's likely to be dry eye based on triaging questions, I'm going to give you my 4 favorite triage questions in a second. Then you go into symptomatology. And in symptomatology, you're really looking at some sort of questionnaire, something validated, gives you an idea of the answers. And then you go into the diagnostic testing. You have non-invasive breakup time, which is what an OCULUS can provide. Osmolarity was one of the recommendations, or corneal ocular surface staining, lissamine or fluorescein. And again, OCULUS will cover 2 of those 3. And so it is a great way to kind of have those. Now, it doesn't say you need to do all 3 to manage dry eye. They said you need to at least do 1, because any of these here, the combination of symptomatology with 1 key good test, is enough to tell you have dry eye. But you could do pure breakup time on an aqueous deficient patient or a terrible evaporative dry eye patient. You still get a bad breakup time. It doesn't tell you what they have. You do osmolarity. You can do a 330 on a patient who could be aqueous deficient or severe evaporative. Wouldn't tell you the type. Same with staining, except for a few unique patterns. They would just tell you that it's dry eye. Then once you've decided, yep, this is dry eye, then you have to decide, okay, what type? If it's evaporative, which is our meibomian gland related, one of the best things you can do is express glands or look at meibography, something, again, an Oculus keratograft can do, is look at the meibography. But that was the recommendation. And if it's based on aqueous deficiency, you would look at the tear meniscus height. And again, you'd be able to do this with an Oculus or at your slit lamp, but it gives you a lot of that information. So let me show you how you put this into practice. And yes, there's a lot of differentials that can play a role, and that's why it's so important to differentiate. Do they have dry eye? Do they not? It could be GPC. It could be Salzmann's, epithelial basement membrane dystrophy, conjunctival chalasis, toxicities you see in the bottom. All these things can feel like and sound like dry eye. In fact, there's a very large list of conditions that often have normal testing, but have classic symptoms of dry, burny, gritty eyes late in the day and on the computer. And so my point to this complex little section here is just the fact that you want to also be sure, what you're dealing with. That's why advanced testing is so valuable. If you just went off symptoms alone, as you see here, symptoms of dry disease were normal, you would actually, according to a study by Anthony Braun, be wrong between 30 and 40% of the time. Imagine remaking glasses 40% of the time, or having to replace contact lenses 40%. None of us would be able to survive. Dry eye is the same thing. If you're making just based on symptoms, you're not going to get there. I like what Crystal said. They send her patients because they said, this doctor, she has the equipment now. She's being humble. She has the knowledge too. But nevertheless, the equipment makes a difference. And then you're not looking at these patients who have dry, gritty, burning eyes and finding that you treated them for 6 months or a year and they didn't improve because they had Salzmann's or conjunctive occultation or concretion or episcleritis or eye misalignment can give you sensations of dry, irritated eyes, especially late in the day and on the computer. So there's so many of these things that can contribute. Here's a patient who came into my office, has been treated for 5 years. Fortunately, the staining did give some of the answer away because there's a lot of tracking up there, and I averted his upper eyelid, saw a large concretion. He had 3 in the other eye. We removed all of them. He called me literally a week later, said, Dr. Karpecki, I've been treated for 5 years with everything under the sun, and I have no symptoms today. He had concretions for 5 years. Now, that's a rare example and obviously an extreme example, but nevertheless, all his testing was normal on these high technology tests, and that's what really made a difference for me to start looking for something else. Education, I don't need to go into this. I thought Dr. Brimer covered this extremely well with the importance of education. I can't emphasize or agree more. That is critical. So I'm going to take you through a little bit of the treatment. One of the key things you need to look at, though, as you're asking patients about this are the 4 triaging questions that are so important to this. And they're coming up. I'm sorry. I'm going to jump back to them. So 4 triaging questions, because you see a very high incidence of dry eye. What's really interesting about this slide is not just the high incidence, but the fact that younger people are getting dry eye much earlier. The incidence of people in the Beaver Dam study, that's the population over age 40, was about 14%. Look at these patients in the 21 to 34 age category, almost the same. There was more, according to this BOSS study, there was as much dry eye in the children of the Beaver Dam patients as there was in the parents. And age 21 to 34 was about 13%. Men and women about the same until you get into the late 30s, early 40s, and it kind of increases for women more. So here's the 4 triaging questions I'd recommend. I cannot take any credit for this. This came from the Optometry Dry Eye Summit that was performed in Denver in 2014. So they brought in a big group, around 30 dry eye experts at the time in optometry, and we came up with certain things that we thought could move the profession towards doing more and succeeding more in the area of dry eye for their patients. So one of the things we thought was really these 4 triaging questions you should ask every patient who's over age 14, really, because actually, according to Priya Gupta's study, dry eye, because the digital devices starts probably around age 4 to 6 in a lot of these children who are on digital devices all day. So we may want to be checking them earlier, but certainly above age 14, do your eyes feel irritated, dry, or do they burn? So basically, how do your eyes feel? Are your eyes red? That is, how do they look? Do you experience blurred vision, especially fluctuating vision? Again, Dr. Brimer covered this really well in her examples. And do you have or feel the urge to use artificial tears? And I guarantee you, if you just ask those 4 simple questions to every patient that comes in, you're going to diagnose dry eye sooner. You're going to have a better idea. Now, you do have to have the testing to then follow it, and that's why we're doing a webinar that involves the OCULUS Keratograph. But I do believe that all of that comes together once you start asking the right questions and you keep your patients in contacts longer, have less glasses remakes, less IOL miscalculations, and the list goes on. So anything such as how your eyes look can show up also on the keratograph, as you see in this image. There's a patient that's being treated age 43 beforehand, and then you can see over time, you've got a bulbar score, it comes right to you on what it is, and then it's starting to drop at a month, but not a lot. By 3 months, 1.6, by 9 months, 0.8, and that's exactly what you want to see in these patients. And most of them see it, but sometimes they don't. So being able to show them that difference plays a role. I already mentioned there are a lot of predisposing factors to dry eye disease, from systemic diseases like diabetes and rheumatoid arthritis, as well as thyroid disease, to age and gender. We talked about environmental contributors like digital devices, and I don't think smartphones are going away. So all we can do is treat these conditions and identify them sooner, but you can see a whole host of them. And there are all kinds of other technologies that are incredibly valuable. For me, the combination of osmolarity and the information on a keratograph is everything I would need. And I don't know that I'm not saying you have to have this to start dry eye. You have to just start. You have to express glands, which takes 5 seconds. You know, you have to do some of the basic things at the beginning. You don't need to have all the best, but if you really want to get into this and you want to make a big difference and you want to be efficient, you have to have these technologies. I mean, it sounds terrible. I spend 3 to 4 minutes with a patient. I saw 60 patients in a day a week ago with my team, all advanced dry eye. Nothing is like a basic follow-up or a post-op or anything. And no patient really felt like they didn't have enough time because I was just educating, going through the data, and everybody did the work ahead of time. I knew the osmolarity. I knew what my Bowman glands looked like. I expressed the glands, and I knew what the staining looked like, and that was about all I had to do before discussing the type of dry eye and talking about the treatment with them. And so these things play a much greater role than just accuracy, and they're extremely accurate. If you don't have the disease and you do osmolarity, you're going to get a number between 280 and 295. Both eyes are going to be within 5 units. Very hard to mistake that as dry eye disease because it's not. And you can start looking for one of those other things I showed you earlier. Now, when you do have dry eye disease, you're usually above 300 and it's very unstable. The Oculus keratograph 5M has been incredibly valuable because it just takes everything you need and has it done beforehand for you. And that's where the value is. Corneal staining. We talked about, again, corneal staining, osmolarity, tear breakup time. Just tell you if you have dry eye when you combine it with symptom questions. Don't tell you the type. You then have to differentiate, is it evaporative caused by the meibomian glands or is it aqueous deficient? So first we're looking at the type. And here we see corneal staining, kind of a little more inferior, but really across the cornea it's mainly micropunctate. I think that's a good indication of dry eye disease. You can actually grade it all the way through different areas, different levels. You can see what it is. Lissamine green is valuable in terms of knowing where the keratin is, knowing the line of marks, knowing where the friction is taking place. So a lot of value to having that information. As Dr. Brimer talked about, I think one of the most favorite tools is non-invasive breakup time. The problem with invasive breakup time is it, one, takes too long. The minute you put the dye in, you've got to wait 2 to 4 minutes to get stability. And I just don't have that time. That's my whole exam with the patient. I'm not going to be able to do that. Number 2, what if I put too much? What if I put too little? How do I keep it consistent the next time? I mean, it's only, according to experts, about a 69% predictable test. That's actually really considered high, but that means you're wrong 31% of the time. When you go to non-invasive, you go to the highest level. And if you look at the TFOS-DUCE report, DUCE-2, it did say there's a high recommendation for non-invasive breakup time, and the data is incredible in terms of the superiority of non-invasive over invasive because of investigator error and because of doctors looking at it differently, mistaking what's EBMD for breakup or not putting enough dye or putting too much dye or not waiting 2 minutes, et cetera, et cetera. This is objective. It tells you what's going on. It measures each of the quadrants, as Dr. Brimer explained so well. So you can look at the location of where it's breaking up, the amount. Obviously, those redder colors are quick breakup times. Then you have a graph showing the breakup time before the blink. You can compare improvement over time. These patients, this is incredibly valuable. You can see this happening. You can show them what we've done for them because Dr. Brimer said we're getting compliant with the medications, but it does a lot more. It does topography, tear film ocular surface assessment, anterior segment imaging. It's got wonderful topography. It's one of the best units for a straight topographer, but I use it, of course, for a lot of things beyond that. The dry eye in particular, as we're talking about today, but keratoconus indication, horizontal visible iris diameter for scleral fitting and contact lens fitting, K readings, RGB fitting displays, the wave, the eye space, etc. But back to dry eye, 2 things that I find incredibly valuable is the breakup time, which kind of tells me if it's dry eye or not, and then that tear meniscus on the right, too, can give me an idea of the type that's playing a role and what's there. Even the little imaging of the rings, the placido rings, can tell you a lot about the regularity of the cornea. So back to the TFOS-DUCE-2 algorithm for diagnosis. Triaging questions such as, how do your eyes feel? How do they look? Do you have fluctuating or blurred vision, and do you feel like you have to use or are using artificial tears? And then into risk factors, and then into a questionnaire. Then, do they have dry eye? That is based on a non-invasive breakup time, osmolarity, or surface staining. And then once you say, yes, we have dry eye, is it evaporative based on expression, or is it aqueous deficient? And expression and meibography, I should say, or is it aqueous deficient based on tear meniscus height? and then you go past what we talked about earlier. So here I want to show you real quickly the value of expression. It takes all of about 5 to 10 seconds, whether you use a Q-tip, a paddle, your fingers, but you want to express the lower nasal to central glands. They tell you more about what's going on than anywhere once you've determined it's dry eye. And this patient obviously is very advanced, very thick eyelids, telangiectasia, nothing's coming out. Finally, I get toothpaste out of 1, maybe 2 glands. I'd have to say that's a grade 3 to a 4. That's a very advanced out of 4 level. Mybography, should look like that, but in this patient, he looks like that. And so it kind of tied in beautifully to exactly what we saw. Now, the value of mybography is I'm surprised how many sometimes when I press on someone's glands and I can't get anything out. I don't know if the glands are atrophied like this patient or they're just congested. I've gone and looked at the mybography and had a complete set of glands, and yet I got nothing out of the glands. So that's a completely different approach to management than someone who has only, as you see here, 20% of their glands left. So it really is important to not just know what's coming out. I think that's critically important, and it's quick and it's an easy test, but then to understand what's happening. And as Dr. Brimer explained so well, what a wonderful way to teach. I mean, I don't have to do much but show them this picture, and it speaks for itself. Most people look at it and say, okay, doctor, what do we got to do to keep these in? They also say, could my eye doctor who sent me here, could they have done something for me? And I always have to remind them, no, we didn't know this stuff. But now we do, and now we have a wonderful opportunity to make a difference for these patients, what they should look like, what they may look like. And then you can compare and look at the eyes and look at the eyelids, look at those differences. You can show the patients what it should be like, what happens as it progresses, all of that. And then treatment in the DEWS 2 starts with education. And I think that was extremely well covered, whether you use Rendia or whether you use your own little eyeball, model to teach. I think the best teaching is an image, as we talked about, and maybe some of these wonderful animations. But if you show the patient their own eye, you explain what you're concerned about, you tell them what happens if we don't treat them, being, progressive and chronic, what will happen, I think your compliance goes up remarkably. And remember, if the patient's not compliant or they choose the wrong products, they still are going to blame the doctor for not getting better. So it's part of our job to help with that, to choose what's going to work, what they can financially afford, what makes sense, but to help with compliance through education. And I think really one of the best ways is to show images of their ocular surface, their meibomian glands, etc. As far as TFOS DEWS 2, they basically said don't think of the options for treating patients as steps, but then they called them step 1, 2, 3, and 4. But Lyndon Jones credit, he did a great job with this treatment section. He led that. He had a great committee. But he's right. You can't suddenly go right into only step 1, then step 2. You got to look at where the patient is. But one of the most important things is education, as it starts there. Modify the environment. Try to quit smoking, try not to cut back on, get more sleep, less digital devices, all those things that can play a role, which I know are difficult. And then warm compresses were recommended, hydrating compresses and lid hygiene. And then by the time you jumped up in disease based on what we just looked at, then you're looking at non-preserved tears. Demodex is present. You want to be using tea tree solutions where punctal occlusion comes in. Then your lifitegrast, your LFA1 antagonists, your cyclosporins, your steroids, and how they all fit in, and your in-office procedures such as LipiFlow, now things like iLux, intense pulse light is even mentioned in these. They went through an incredible array of options that work for these patients, as I mentioned, punctal plugs, etc. But here's why it's so important. I take this data all the way back from about 18 years ago. This was in the pivotal trial, actually 15 years I should be to be exact, 18 years when this was done, but 15-year data. And in this pivotal trial, they looked at what happened to the group of patients who were on one of the best artificial tears, at the time called Endura, very similar to what we have today known as Mega-3 by Allergan, Refresh Up Team Mega-3. Very, very good artificial tear. But even in the group that just had artificial tears, the inflammation increased by almost 40% in 6 months. That means artificial tears do not control this disease. It's truly progressive. It's damaging. You've seen what happens to meibomian glands over time, lacrimal glands, ocular surface. You can't bring those glands back. And so the key is really to understand what's going on early. If you had a person who came in with, and Holland uses this, of pressures of 40, you do something about it. If they come in with osmolarity of 330, you do something about it. If they come in with meibomian glands that are showing damage, you don't wait. You don't wait till the glaucoma person has visual field defects to say, okay, now it's time to treat you. we have to do the same thing for dry eye. We have to look at it as a progressive disease that needs to be treated at the very early stages. And the best way to catch the early stages is to have the technology and have the understanding. And hopefully today, through the Oculus Cartograph education and through what we provided, we can give you a lot of that. One little quick summary that I think really encompasses a lot of the treatment algorithm. This is my own. This is not from TFOS Dues 2. But I realized that what made things really successful in my clinical practice, and I'll do this in, I have 5 minutes, but I got to do it a little quicker than that. We've got more time for Q&A. But what really made a difference for me is the fact that when I started treating evaporative dry eye 15 years ago, or even 10, 12 years ago, I was making a huge mistake, and I was treating one element. I would put them on a tear, which treated the tear film instability, or I would put them on Restasis, and that alone, and it treated the inflammation. But I was missing the other elements. These glands are obstructed. That's why the stuff's hard and won't come out. My myography shows that atrophy over time. Inflammation is definitely there in every form of dry eye. There's biofilm. If you think about the blink rate, which is the ultimate culprit for why we have so much meibomian gland dysfunction, which leads to evaporative dry eye, is the fact that our blink rates go from 17 to 20 times in a minute in conversation to 4 times on a digital device, according to a study by Patel. When you drop your tear film blink capacity by 80%, blink does 3 things. 1, it pumps the meibomian glands. No wonder they get obstructed. Number 2, it causes exposure when you don't blink enough with a good tear film, which leads to inflammation, tear film instability. And number 3, if you look at an eyelid tomorrow at the slit lamp real closely, when the patient blinks a normal blink, you'll notice that the lower eyelid moves nasally. That's a cleaning mechanism. That's there 17 times a minute, but not if you're not blinking or you're using digital devices. It's 4 times, and you get a biofilm formation. You get more blepharitis. I started realizing when I controlled all 4 of these elements, I had this huge impact in my patients. I mean, it went to an entirely other level where we can see 60 patients because we know what to do with each one and how to get them there and what works. And this was the key: obstruction, inflammation, biofilm, tear film. Now, aqueous deficient have a different algorithm, neurotrophic have a different algorithm, and neuropathic dry eye have a totally different algorithm too. But this is the most common disease. This is 86% of all forms of dry eye disease. So I found that if you took one treatment in each area, depending on severity, you could really impact these patients. A person who had, mild dry eye, I can get away with thermal pulsation, like a moist hot compress. If they want to do thermal pulsation, great. But if I just did a Bruder mask, they'd do fine. And I could do a lid debridement in the office. I could use lid scrubs for their eyelids. I might put them on an omega fatty acid, and I'd put them on a good lipid tear. And you know what? They've covered each element. They'll do great. But if they were end stage, like that gentleman I showed you had one gland producing toothpaste, you looked at his myography on the Oculus Cartograph 5M, and you saw he lost 80% of his glands all in that area, especially. He's too advanced. For him, for obstruction, I'm talking about thermal pulsation. I can't lose any more glands. I'm talking about lid debridement. I'm still going to give him a hydrating compress. For the cleaning, I might use hypochlorous acid or do an in-office treatment known as a Blefex. For inflammation, I'm probably starting him on corticosteroids and oral doxycycline because I get a lot of inflammation controlled in this meibomian glands. And then for tear film, I'm not going to do punctal occlusion at first, but I might do it later. And I'm probably going to use these very significant osmolarity lowering tears, the TheraTears, the Blink, the Oasis tears. Those Oasis Plus, those are the ones that lower osmolarity much faster, and they do an incredible job in those high osmolarity patients. Although there are a lot of new drops coming out that are very good as well. My point is, no matter the severity, I never missed one of these elements: obstruction, biofilm, inflammation, and tear film. And TFOS Dues 2 indirectly kind of capture this too. It's just my own twist on it because I've been doing this for about 8 years with these 4 components. But I really feel like it's made a huge difference in the impact and the improvement on these patients. But it all starts with the right diagnostics, and I think that's what we hopefully brought to you today. So we're about 1 minute before I was supposed to end. So let's open up the lines, I guess, Chris, for any questions from our attendees.
Yeah, thank you, Dr. Karpecki. And also thank you, Dr. Brimer. Excellent presentations. Just in case you missed part of the presentation or would like to review it, you'll be automatically emailed the recording tomorrow evening. If you have any questions regarding this webcast or any questions about Oculus devices, such as the Cartograph 5M, you can contact us at sales@oculususa.com or 888-284-8004. So now we'll go ahead and get into the questions and discussion. Just to remind everyone, there's a text box for questions on your GoToWebinar control panel. And if you put the questions in now, we should have time to get to them. So Dr. Brimer and Dr. Karpecki, if you're ready, I'll go ahead and start reading these off.
Sounds great.
Dr. Brimer, Crystal, would you tell us the test you are using for the screening again?
I use tear meniscus height, non-invasive breakup time, and the redness. Now, it takes, like I said, about 2 minutes. If we don't have 2 minutes, you say I've only got a minute, then you could switch out the nick butt, the breakup time, for interferometry, and it's still going to give you an assessment of the amount of oil in the tear film. So you're still looking at those categories of water, oil, inflammation, snapshot at least.
Okay, thank you. So this is actually 3 questions, but I'm just going to read them all off in sequence because they're sort of related. What do you feel the role of tear osmolarity measurement is? How do we evaluate goblet cells? And the last question, what does the abnormal nick butt tell us? Is it abnormal lipid layer or abnormal mucin layer?
I'll be glad to start it. So the first question on tear osmolarity, I think it's my most valuable quick test. It just, what makes it so valuable is it identifies really early dry eye disease. Number 2, it's the most accurate test we have on the market. People who question if it works, I question their knowledge of dry eye. I mean, every day I'm reminded how incredibly accurate this is. Now, no test is perfect. If the technicians don't measure it properly, you can get some variability. If the patient puts a drop in her eye beforehand, it's not going to give you what they have. They shouldn't put any drops in for at least 2 to 4 hours the day of the exam. So there are elements of it. And even then, it's only 87% predictive, which is, again, the most accurate test we have, but still 13% off. But where it's valuable, I think, is when you don't have the disease. If you have a reading between 280 and 295, both eyes within 5 units of each other, you probably have a 2% chance of having dry eye. And that's hugely valuable because in the past we would put a person on a tear, a drop, a medication, we do something for the obstructed glands, and 6 months later they're not better. Well, they didn't have dry eye, and the only other thing that's going to give you that early is osmolarity. They might have had some minor staining. They might have had symptoms. They might have had even meibomian gland deficiency issues very early. So it doesn't look right. It looks like the dry disease, but it's concretions, it's misalignment of the eyes, it's epithelial-based membrane dystrophy, allergic conjunctivitis, blepharitis, GPC, limbal stem cell deficiency. The list goes on and on and on. So that's where the value comes in. But I find it indispensable. And when they come out with MMP9 at the same time, which I think is supposed to happen within the next few months, and then I've got 2 key measurements, all done within 5 seconds of testing. And now I could really put things together, knowing when to punctal occlude, when to treat with steroids versus other drops, to make sure I had lifitegrast or cyclosporin involved. So I think it only is going to continue to advance and become critical. The second one I think was related to the type of, I'll take the third one, that if you had some sort of, how do you look for goblet cell issues? You know, it's a little difficult, but the best is lissamine green. It's hard to get that dye. I don't often use it because I have osmolarity finding the early diseases. So I've been switching to that for efficiency. But if I had the perfect world where I could see, 20 patients in a day again, and I had the time, lissamine is hugely valuable for mucin deficiency. It tells you a lot of what's going on. Impression cytology is your best approach, but that's not clinically relevant. That's more research right now. It doesn't give us that opportunity. There are people working on more practical tests like that for us in the future, which can certainly help out. And then non-invasive breakup time is just a much more accurate way of looking at breakup time, but unfortunately it doesn't really differentiate the types. It could be aqueous, could be mucin, it could be evaporative. All it's going to tell you is that it's not stable. And so there's great value for that because that helps you know it's dry eye, but then you have to go to the next step, which is what's coming out of the glands, what's the meibography look like to determine if it's evaporative, or what's the tear meniscus height to determine if it's aqueous deficient. And at that point, I think you get a much better differentiation. But tear breakup cell itself is just a very good, especially non-invasive, very good overall test for dry eye, as is osmolarity. Just an overall test, doesn't differentiate the type. Same with staining to a degree. It's just a good test. It doesn't differentiate the type either.
Well said.
Okay, So, okay, on to the next question here. We've got a few piling in, so I'll try to get to as many of them as possible. When do you recommend gland treatment such as LipiFlow or iLux? How bad do the grading scales have to be on the Keratograph 5M? Even level 2 low, or would you watch and compare next year?
Personally, I don't like to wait to intervene, and maybe it's perspective of just seeing so many people come in who have lost so much. And, you know, I think every case is different on how quick and how aggressive that loss is going to be. And I put it together with the whole story of what does the rest of the ocular surface, how does it present, how symptomatic are they? And also looking at it and saying, okay, out of their list of issues and instabilities, how does this one rank? Is it the #1 issue, or is it a secondary issue? And if we have raging inflammation, maybe if we focus on that, we're not going to lose as many glands as quickly. But for me personally, I do it fast. I'm always going to mention it as soon as I see any loss or any stagnancy on expression. I just may not be as adamant about it if they have a nice lid full of glands.
I'm identical to that, so I'm going to reiterate it because I couldn't agree more. So I mean, I bring it up if I see that they have a good array of glands, just like Dr. Brimer said. But I say, you know, you've got so many glands. If you had one of these, it would speed the process up. You might be one of those people that doesn't like to use compresses or doesn't like to use cloud. Compliance may be an issue for you. I don't say those words, but for your purpose. And if I determine it is, then I say, you know, this is a better option. It might help you. But I would also say, like Dr. Brimer said, you know, you've got a nice complement of glands. I see them all here. That gives us time. You know, you've got plenty. We can start you on the comp. We can look to using the iLux, the LipiFlow if you don't get the improvement you need. Whereas a person who's down to 20% of their glands, or even if they've lost more than a third, as Dr. Brimer said, it's very unpredictable when they start to really go downhill. So if they've already lost a third of their glands, they've truncated a third, they're missing to the base, 50% and above for sure, then I say, you know what, to me it's like a person who's lost peripheral visual fields, back to our glaucoma analogy. I'm not going to say, you know, you're too far gone, we might as well not treat you, you're going to go blind. No one would do that. Same thing here. A person who's lost that many glands, now I'm desperate to get them controlled. I'm going to highly recommend they have some sort of thermal pulsation option, such as iLux or LipiFlow, and probably debride their eyelids and clean that up, because I just know if I don't and control the inflammation, as Dr. Brimer said, they're going to progress on me. I've tried having patients, you know, where we said, hey, let's just start you on some treatment, and then we bring them back and we look at the myography. And if you do that and they change, every one of those will do whatever you want them to do the next time. But I'm of the mindset of Dr. Brimer. I know that what happens, I know how this progresses. I'd rather at least give them the options early, depending on the type of patient they are. There's someone who's willing to do compresses and lid hygiene every day and follow those things. With a whole complement of glands, I think that's fine. And if they're not, then we still have this option even in that category.
Well, and to add to that, Paul, I tell them this is a line in the sand. This is going to help kind of reset things, evacuate the glands, but it's up to you to change the environment that got us here. And if you're, like you said, if you decide you're not going to do that and you'll just have it repeated when you need it, that's okay too. But I want to give you the options so that you are in control somewhat of that longevity and maximizing the effect. And the other thing I would say, you mentioned debridement a couple of times. Ever since the day I was in your office and saw your Karpecki debrider, I absolutely love that, and I use it every single follow-up, every single dry eye patient I have. Maybe therapeutically, but honestly, I use it diagnostically to see what's there, and then knowing in the back of my mind it's going to help them if I get rid of it as well.
That's great. Yeah, I know to brag about it, because I mean, just debridement, whether you use my tool or any, is really remarkable, because I can't tell you, if I don't remember to do that at the end of one of these follow-ups, like you said, the patient will practically tackle me before I leave the lane.
They do.
And I do that thing to my eyelids. It just removes stuff that's been building up there for so long. And I'm always amazed at how much you can get off the eyelid. And no wonder those glands aren't functioning with all that keratin and on top of them. And then, you know, next level up SpleFX. I mean, that you can get rid of everything in the lashes, which you can't do with the debridement tool. You get rid of all the biofilm around it. You know, a lot of things. So I'm a big believer in that whole component, as you just said, Dr. Brimer.
Okay, so I don't think I'm going to be able to get to all of these tonight. So I'll try and get through ones I think are most relevant to the presentation here. Do you recommend screening every patient that comes through the door, or just those that respond positively to triage questions?
My clinic is the triage questions in the general clinic. Now, my clinic, my main clinic, like at Kentucky Eye Institute, is all referral based. If a patient tries to come in on their own, the earliest appointment, I hate to say this, but it's 4.5 months from now. But if they go through a doctor, we have slots. So we're not keeping our referring docs waiting that long. So every patient's pretty much referred in. I know they have dry eye. I'm going to do very similar to what Dr. Brimer does for all of our testing. But in the general clinic, we have a general clinic. I have a colleague, optometric colleague, who does a lot of good practice across the board. He uses the triaging questions before doing all the other stuff, and that alerts him to saying, hey, we need to look into this more. Dr. Brimer, I'd love to know how you do it.
Well, and I think the key too is fitting into your flow so that you will be consistent as a doctor and you'll hold your staff accountable and that they'll be bought into doing it where it doesn't mess up the flow. So when I first started, I used 4 questions. I think one of them was different than yours, but same basic premise, and we didn't have them on paper, on a form for them to fill out. It was laminated, and she did it during the workup. She did the AR, she did the OptiMap, and say, would you answer yes to any of these questions? Because I just don't want to slow down the flow with surveys. And if they said yes, then we would move on from there. And sometimes we would show them a list of medications and say, oh, well, you've got this, you're taking this, you have this is making you more prone to dry eye. Let me do this complementary test. If we had the time, we would do that so that it set the stage. Then once I was really incorporating the 5M to its full capacity, we just kind of skipped all that and we do that screening. And again, the tear meniscus, the interferometry, a lot of times because it's quicker, and the redness. And I do that probably, it's not because it doesn't take longer. It's just the fact that it gives them something to walk out with. So I think in the big picture of things, even though the triage questions are good for us to pick it up, it doesn't leave an impact on them. And so if they didn't answer in a way that they thought was convincing, if they didn't believe they had big enough symptoms, then it may fizzle out if all I do is the triage questions. I think they're useful, especially if you're not doing anything. Definitely do it. There's no way that it could really mess up your flow at all. All it's going to do is benefit you. But if you have the ability and the time, do that technology screening with the 5M so they leave with something.
Yeah, it's great. That's the ideal way to do it.
So guys, despite the number of questions, which is obviously a good thing, people are really interested in your presentations. I'm going to take a couple more here, and then I think we'll call it a night, if that's okay with you. How often should mybography be performed?
That's a good question. You want to take it first this time, Crystal? I'll take the second. Actually, I guess you took the last one first. I guess so. I would say, you got to do a little bit. I wouldn't do it as a screening. I mean, I love the idea. It seems perfect in the real world. In a clinic, it's hard to do that as a screening kind of device. I would say that I'd like to have some quick triaging questions, and I got to express those meibomian glands. Remember, almost 80% of all the oils coming from your meibomian glands, according to a study by Corbin Blackie, of the quality glands come from the lower eyelid, nasal to central region. So that's the only place you have to express. And if I'm seeing abnormality there on expression, and I've got some of the triaging questions that are saying yes, and even the predisposing factors, I would say that I would bring the person back in for an eval. It's going to do a dry eval. And then that's where mybography is absolutely critical. If you had a practice that you were just trying to establish yourself, get yourself going, making a difference, differentiating yourself, standing out and building your practice. If you could do mybography on almost every patient, every contact lens wearer, I think you would go extremely far, or any of the screening type tests that Dr. Brimer described. But I think I like to kind of do that preliminary stuff and then verify what's going on. As I said earlier, I'm surprised many times when I think that I could express and know what's going on, only be completely blown away by what shows up on the mybography. And So that's why they're so valuable together. But if there's no abnormality, nice olive oil is coming out of the glands, I don't see the point in getting a meibography.
When I have a dry eye eval come in, they're absolutely going to get it as part of their workup, and then I'll do a little mini eval at the very least yearly. And at that point, we're stable, but I still want to prove that, all right, you know, I put up the screen on the 5M that has the old picture and the new picture right next to each other, and we can literally go gland by gland and see if there's change. So I'll do that annually. As a screener, my ideal would be to do it on everybody. We're actually looking into putting it in the optical and trying to figure out, you know, is there privacy issues? What can we do to really just spread the word, you know, to make them more aware, raise awareness, get more referrals and just more buzz about this so that people want to take care of themselves and get the care they need. But I also, if it's a device user, absolutely, they're getting it every year. Or if it's just somebody that's at higher risk, we're not going to skip it. Ideally, we're doing it on all of our routines once a year, but that doesn't always happen.
Okay, and then I'll sorry. Do you have something to add?
I agree. So go right ahead, Chris.
So at what point during the evaluations do you recommend procedures such as LipiFlow, Procara, etc.?
I do it at the end.
Yeah, I'm at the end. That's the wrap up. That's the end. Go ahead.
Well, when I tell that little story and I've got their collage up, I walk them through for 45 seconds or so, and then I say, so here's what it looks like. Here's our number one problem. Here's our number two, and here's our options on what we can do about it. This is what I recommend, and I just try to put a bow on it and give it to them in a concise enough manner where they're not overwhelmed, but with enough detail where they understand and they're motivated.
Yeah, I'm the same thing. Like if I decide it's evaporative dry eye based on meibography expression and early testing, I pull out that sheet that I showed you at the end that had the 4 categories: obstruction, inflammation, biofilm, tear film. I say, here's the 4 things we're going to have to work on based on this disease. I explain why they're there in about 30 seconds, and then I make my recommendations in each of the categories based on the severity of the condition. And then I hand it over to Carla. Usually she's my quarterback in the office, and we have a good staff that works with her and as part of our team. But she kind of then takes it and says, okay, this is what Dr. Karpecki recommends, goes through the details of how to do it, and then we bring them in another day, of course. So you have procedure days where we just do, I mean, if it's emergency amniotic membrane, someone coming in from a long distance, I'll do them right on the spot. But if it's something that, you know, we have to debride something, or we could do it later, or especially iLux, LipiFlow, BlephX, you know, we'll bring them back on procedure days, and we'll do, you know, 20 to 30 in a day of those. And they all seem to, patients are all lined up, knowing each other, they talk about it, they do well. But it's all based on that initial recommendation, then the handoff to someone who could explain it much better than I do to the patient, and I'm already in the next room, and I have a scribe there, and then she follows afterwards, does the same thing, and we kind of just do that all day. But it all comes into the wrap-up and really to that end point of making a recommendation based on what you're there. But I do ask a few questions. You know, I want to know what they're like with compliance. If they're someone who probably, you know, will do things I recommend versus not, and if they're more severe, I try to tell them you've got to do one of these more advanced procedures. If they're early in the disease, I can talk about options, but overall, I think it comes in after you've explained the condition, educated the patient, then you make the recommendation and hand it off.
Okay, sounds like you guys are in agreement with that. So with that, I will go ahead and end the Q&A session. Thank you, Dr. Karpecki, and thank you, Dr. Brimer, very much for the excellent presentations and for sticking around for the Q&A for an extra 15-20 minutes. And I'd like to thank everybody in attendance tonight. And again, if you have any questions on the webinar or any questions on the Oculus devices, you can contact us here with the information shown on your screen. And then with that, I'll wish everyone a good night.
Okay. Thank you, Chris. Thank you, Paul.
Thanks, Chris. Good job,
Thank you.
Crystal.
Good night.